If you're a physician using AI today, you've probably wondered which tool actually belongs in clinical practice, Doximity GPT or OpenEvidence. On the surface, they appear similar, but they are designed for very different clinical moments. Using the wrong one at the wrong time can slow you down or introduce risk. In this video, I'll walk you through how physicians actually use these tools in real workflows without hype or exaggeration. Artificial intelligence is no longer optional in modern medicine. Many clinicians are already using AI tools daily, whether they admit it or not. But not all AI tools are designed for the same purpose. Some are optimized for speed and structure, while others prioritize evidence, depth, and academic rigor. Confusing these roles can lead to frustration, inefficiency, or inappropriate reliance. Understanding the difference is essential for safe and effective use. Doximity GPT functions as a clinical workflow assistant designed to support physicians during real patient care. It helps clinicians think through differential diagnoses, initial diagnostic workups, and first-line treatment plans. This is especially useful in fast-paced settings such as outpatient clinics, urgent care, and telemedicine visits. Its core strength is speed and structure. It helps organize thinking quickly, but it is not intended to replace guidelines or clinical judgment. It is important to understand what Doximity GPT is not. It is not a comprehensive literature review engine, and it is not designed to deeply analyze competing clinical trials. While it may reference general recommendations, it should not be treated as an authoritative source for nuanced guideline interpretation. Its value lies in helping clinicians move efficiently through common clinical scenarios, not in replacing primary sources or institutional protocols. OpenEvidence is an evidence synthesis platform focused on clinical literature and guidelines. Its primary role is to analyze and summarize peer-reviewed studies, consensus statements, and practice guidelines. Physicians often turn to OpenEvidence when facing complex or controversial decisions, or when they need to justify a particular approach. It is especially valuable for academic discussions, teaching, and situations where evidence transparency matters. OpenEvidence is not optimized for rapid point-of-care decision-making. It is intentionally slower because its priority is depth rather than speed. In a busy clinic or urgent care setting, it may feel cumbersome for quick questions. That does not make it inferior. It simply means it serves a different role. Understanding this prevents misuse and unrealistic expectations. Here is the simplest way to remember the difference between these two tools. Doximity GPT answers the question, what should I do right now? OpenEvidence answers the question, what does the literature support? Both questions are valid and important, but they arise at different moments in clinical care. Recognizing which question you are asking determines which tool you should use first. Consider a patient presenting with vague abdominal pain in a primary care or telemedicine setting. You need to think through a differential diagnosis, decide on basic laboratory testing, and identify red flags that require escalation. Doximity GPT fits this moment well. Now imagine choosing between two guideline-supported therapies or explaining your decision to a colleague. That is when OpenEvidence becomes essential. Pause for a moment and think about your own clinical workflow. How often do you need a fast, structured answer, and how often do you need to justify a decision with evidence? Most physicians already make this distinction intuitively. AI simply makes the choice more explicit. Being intentional about which tool you use improves efficiency and reduces cognitive overload. For high-risk clinical decisions, many experienced physicians use both tools. They start with Doximity GPT to organize their thinking and then confirm the approach using OpenEvidence. This double-check strategy combines efficiency with safety. AI should support clinical reasoning, not replace it. Judgment, experience, and patient context remain irreplaceable. The most common mistake clinicians make with AI is treating it as an authority. Both tools can hallucinate, oversimplify, or miss important nuances. Neither understands the full context of your patient. Responsible use requires skepticism, verification, and alignment with local guidelines. AI is powerful, but only when used thoughtfully. Doximity GPT is optimized for speed, structure, and clinical workflow. OpenEvidence is built for depth, justification, and evidence transparency. Most physicians do not choose one tool over the other. They combine both intentionally. When used correctly, these tools reduce friction while preserving sound clinical judgment. At this point, it is worth reflecting on how often speed and evidence compete in real clinical practice. Medicine rarely gives us unlimited time, yet evidence still matters deeply. AI tools amplify this tension. The risk is not using AI, but using the wrong AI at the wrong moment. Recognizing whether you need rapid structure or deep justification is a clinical skill in itself. Experienced physicians rarely rely on a single AI tool. Instead, they treat AI like a consultant. One tool helps organize thinking quickly, while another validates decisions against evidence. This mirrors how clinicians already work with colleagues. AI becomes an extension of that process, not a replacement for expertise. The key difference is intentionality. The goal of AI in medicine is not automation for its own sake. The goal is reducing friction while preserving judgment. Tools like Doximity GPT and OpenEvidence are most powerful when they support clinical reasoning, not when they replace it. Used correctly, they can save time, reduce cognitive load, and improve clarity. Used poorly, they introduce risk. The most important takeaway is not which AI tool you choose, but how you think about using it. AI does not replace clinical reasoning, it reveals it. The moment you pause to decide whether you need speed or evidence, you are already practicing safer medicine. That habit will matter far more than any individual platform. Technology will continue to change, but disciplined clinical judgment remains the constant. Another important consideration is expectation management. AI in medicine is often discussed in extremes, either as revolutionary or as dangerous. The reality is far more practical. These tools reflect the data, prompts, and assumptions behind them. They do not understand your patient, your environment, or your local constraints. When used as support, they are powerful. When treated as authority, they become risky. Framing AI realistically is essential for safe adoption. Let's walk through this deliberately. Imagine you are about to see your next patient. You have limited time, incomplete information, and competing priorities. Before opening any AI tool, pause briefly and ask yourself one question. Do I need structure or do I need evidence? That single question changes everything. If you need structure, speed matters. If you need evidence, depth matters. This habit alone improves safety, efficiency, and confidence in AI-supported care. Take a breath. Medicine moves fast, technology moves faster, but clinical judgment moves at its own pace. Before using any AI tool, pause. Ask yourself what you actually need, structure or evidence. That pause matters. It creates space, it reduces error, it protects patients. AI should speed up workflows, not thinking. Good medicine still requires reflection. That principle does not change. If you want grounded, real-world guidance on using AI safely and effectively in medicine, subscribe to this channel. This is My AI Doctor, where we focus on practical clinical insight, not hype.